Major support for these broadcasts is provided by the CUNY TV Foundation, New York Community Bank, Kilroy Architectural Windows, New York's window company, Capital One Bank, Perfect Building Maintenance, Chase Commercial Term Lending, Geneva Burns, Giantomasi and Webster, M&T Bank, the Wyckoff Group, Chelsea Lighting, Greenberg Traurig, LLP. Additional support is provided by Ackman Ziff Real Estate, AKA Hotels, Corman Communities, Bank of America, Merrill Lynch, Bank Leumi, USA, Briarwood Organization, CBRE, Colliers International, NYC, Cushman & Wakefield, DDG, Douglaston Development, Levine Builders, Dime Savings Bank of Williamsburg, Eastern Union Funding, Flushing Bank, Friedman LLP, Herrick Feinstein LLP, Hersha Hospitality Trust, Investors Bank, New Banks, James D. Kuhn Real Estate Center at Syracuse University, James Orphanides, Centurion Holdings, John Katsimatidis, Red Apple Group, Margolin Weiner and Evans, Madison Realty Capital, Meridian Capital Group, Newmark Grubb Knight Frank, Popular Community Bank, SJP Properties, Sterling & Sterling, Stonehenge Partners, Urban American, and these friends.
So we were talking last week about medical schools and training the healthcare professionals to take care of what we need for the 21st centuries. And I'm so fortunate that I have 4 fantastic physicians who are heads of medical schools, and I'd like to introduce them and continue our conversation. We have Dr. Alan Spiegel, who is the Albert Einstein College of Medicine of Yeshiva University. Dr. Dennis Charney, who is with the Icahn School of Medicine at Mount Sinai. Dr. Edward Halperin, who's at the New York Medical College. And last but not least, Dr. Larry Smith, who is with the Hofstra North Shore LIJ Medical School. So we were talking about this disparity about income on how we train and get a number of people. The disparity, how do you keep that student really, with that motivation that with what they had the gut when they went there, because I really wanted to do this great humanitarian, and then due to the economic cost over there that we have, how do you keep them motivated, for the 4 years, and then they say, hey, look at that doctor who may be on TV, or this doctor who promotes themselves, or the doctor who's paying for the ads, in the Avenue magazine or something like that. Why should I be a primary care doctor?
So I think one answer always has been the same. If you expose people early in their formative stage to people who become their heroes, they want to be like those heroes. And if we show students and residents really great primary care doctors who love their patients and get a lot of positive good out of that relationship, we'll turn out primary care docs.
Right, I agree with that. One of the things that we did recently, we had not had a department of family medicine at Mount Sinai. And in the last year, we formed a new department under the leadership of Neil Kalman. He runs a clinic in Harlem. And that has changed the attitudes of a lot of our medical students, because they see him as a role model. Yep. And they're going to follow their passion, go into family medicine. But we do have to reduce the disparity in pay. And a lot of the healthcare systems, like ours, are paying primary care doctors more than just what they collect, right, so that their salaries are more in line with specialists, because we need those primary care doctors.
Now, we were talking prior to the show with regard to this about subsidizing, the same way that Dr. Steve Safer, who was a socialized medicine, and I do remember, and this is before you even joined the Albert Einstein, because many years ago I used to teach at Albert Einstein and also at Montefiore. They had a residency in social medicine, right, 40 years ago, 35 years ago. They were
pioneers
They
in
were
that.
pioneers in this. And I remember Dr. Joe Bufford was at Valentine Lane Medical Center, you know, up in the worst neighborhoods of the Bronx. So what about the programs, and Ed brought it up when I spoke to him before, about the programs that you work on the Indian reservation or you work in an underserved area, and medical school, the cost of medical school is, you know, returned. You know, it's like a stipend.
Yeah, those are very good and they're very worthwhile, and they should continue, but they're time limited. So that you might work in an Indian reservation or an impoverished area far from where you might ultimately practice. So you might get 2 to 3 years experience. So that's important. But what we really want to do is train our students to go into primary care, care for the underserved, and stay with that for the rest of their career.
But don't we also need the specialties? Like Ed was saying last week that, you know, we had the situation that, you know, if we didn't have the oncologists and we were talking about genomes over here, we need these other specialties over there. So, you know, there were conditions that we didn't know. You know, the science has changed. You know, I remember, I think it was Israel created something with a camera which went down the digestive system, so you were able to see. Primary care is important for the healthcare system, but we also need definitely the specialties.
Both are
There's a
important.
fair amount of, of data on your question. If you look at what predicts for where people ultimately practice in underserved and rural areas, the most important predictors are where they grew up, where their families are from, because they like to return to what they're comfortable with, and who they see as mentors. As Dr. Smith said, as a role model, I'd like to grow up to do that. On your question of specialties, most American medical students enter medical school wanting to be pediatricians. That's what they've seen, that's what they know. They know they're pediatricians. 2/3 of them put that on the checklist when they start. By the 4th year, they have now shifted into the various specialties because they've seen models.
I heard last week that he wanted to be a basketball player. Then he decided he wanted to be professional. How did you decide you wanted to become a psychiatrist?
Yep. Actually, I did want to be a pediatrician for a couple of weeks when I went to med school. But then, and this gets back to the role model, I met a psychiatrist, researcher, in the medical school that I went to, and he became a role model and a friend, and he helped guide my career. And a lot of times that's what happens. You get inspired by somebody and you direct your career that way.
Yeah, I think role models are extremely important, but as Larry also said, some of our students arrive and they know they want to be a neurosurgeon from day one. Others are quite undifferentiated, and then the exposure that they get to various specialties, to various practitioners. But I think we shouldn't obscure one other fact, and this is relevant to your comment about the altruism of our medical students. You know, and I'm sure these are comparable numbers. We have 8,400 applicants for 183 positions. So we're getting to choose through a very, very selective, rigorous process, people who are extraordinarily motivated and dedicated. And then that translates. Our students volunteer in something called the Echo Clinic in the South Bronx. And they have role models that really emulate that kind of social and compassionate care.
But my question comes back to the fact that we don't have enough physicians out there to take care of our current population and also the additional population, which you've already said to me.
I know we referred to this a number of times in the previous discussion. I'm interested in my colleague's view. I don't want to be simplistic about this. The actual rate limiting thing is not the number of U.S. medical graduates, it's the number of residency slots. The only way you become a practicing physician of any kind, primary care specialty, is to have a residency. The Balanced Budget Act of 1997 capped the number of residency slots in the U.S.
There hasn't been an increase.
So the consequence has been, as we've graduated more U.S. medical students, the gap, which used to be something like between 16,000 U.S. medical graduates a year, I think I have my numbers right, and about 25,000 residency slots, that used to be filled up by international IMGs, international medical graduates. That gap is shrinking as we graduate more U.S. medical students.
And in fact, it's predicted to go to zero.
Yeah, there you go.
Within a short time.
So the real issue is not at the level necessarily of U.S. medical graduates. The issue is, what about the residency slots? And that's a very difficult problem. It's tied in with the huge issue of Medicare and the sustainability of this. I mean, that gets us into a whole nother discussion.
Now, I want to talk you out of what you said, where you said, we don't have enough physicians. We don't have enough healthcare providers. would be the more proper term. Do not fall into a physicianocentric model.
So,
that it has to
so
be
we
all
don't.
done by the medical schools.
You're 100% correct. We don't have enough healthcare providers, and perhaps, as a number of the articles have said, we need healthcare providers in different roles, and the physician should be doing certain parts of the area, such as the nurse practitioner doing more work, different categories over there.
But there is, I think, a shortage of primary care doctors who will work with physician extenders so that we can reach more people earlier in their life for prevention.
Why don't we increase the number of slots in your medical school? Why don't we say that as opposed to 140 and 186 and 196 and hopefully 100 over there, we go up to 300? What is the largest number?
So remember, residency is where you differentiate. So no one graduates medical school as a primary care doctor, right? You go into a residency, either family medicine or pediatrics or internal medicine, and then choose to do primary care. And what we don't want, the worst thing we could have, is to leave primary care somewhat unattractive and have only the people who have no choice because they're at the bottom of the barrel choosing primary care because they, in fact, have no other choice except to go into it. What we want is, again, to return this to following your passion. This has to be about the people who really are passionate about becoming primary care docs going into it. Right now, many of the primary care slots in this country are filled by default by the people who actually would rather be a specialist but can't get into the specialty training program.
Isn't that also true that many of the people who might become podiatrists or other allied healthcare professions became that because they couldn't get into medical school?
In some cases.
In many cases?
I don't really think that's fair to our colleagues. I think the fault is an educational system that does not tell people that there are many options to help people. And TV shows portray physicians and hold a physician out. There are people that can make a great deal of difference as public health workers, as podiatrists, as nurse clinicians, as physicians associates, physical therapists, occupational therapists. And therefore we have to be careful about being physicianocentric and saying that's the center of the universe.
I agree completely with Ed. I think the average high school graduate, even college student looking at health, sees physicians and maybe nursing.
You know, one other area that I think at some point we should discuss, and that is the population is getting older, and there are diseases associated with aging that we do not have good treatments for, and that's where research, comes in. Take Alzheimer's disease. There's a strong correlation that the rate of Alzheimer's disease goes up the older you get, and we don't have acceptable treatments for Alzheimer's disease and other neurodegenerative diseases. So we're all faced with a challenge now with the availability of research funds available to our medical schools to really change the practice of medicine with new treatments. And the frustration is that science has never been better. With the sequencing of the human genome, the opportunity has never been greater, but the availability of research funds, in terms of real availability, it's going down.
But part of this is, as Alan said about residency programs, 1997 they capped that. There are additional charges that the healthcare system is going to have to absorb to take care of the uninsured over there who are now going to be insured. The lack of physicians and allied healthcare professionals. How do we grow this? I mean, what are the solutions? I mean,
Let's come back to what Dennis is saying. Part of the solution is actually research, and research that not only involves high-tech devices and expensive procedures, but actually that prevents diseases. A striking example for me as an endocrinologist, someone who studies hormones, you have programs in every state where newborns are screened for a variety of diseases that are treatable. One of them is low thyroid. You know the term accretin? That's the term for a baby that's born with low thyroid function and the brain doesn't develop. Picking that up and with a simple, inexpensive replacement of thyroid hormone, you've prevented a life of intellectual disability and probably institutionalization. There are many examples, and that was fundamental research that led to that.
But isn't that also, I mean, I'm very involved with healthcare screening. I was involved many years ago at NYU, and then I created a foundation that pays for no cost healthcare screenings. Shouldn't the medical, either the medical schools or the hospitals or the allied care institutions do additional screenings? Because if we had these additional screenings, we'd be able
We have to be very careful. This term screening, I mean, when you start thinking about mammography for women and talking about PSA, prostate-specific antigen for men, you get into one of the most controversial areas. There is a simplistic, and I'm not accusing you of this, assumption that screening, it's got to be good. Not necessarily. You have to actually show that you are being effective and preventing. The example I gave of a newborn with low thyroid is unequivocally the case.
Go ahead.
That's a totally different than what I'm talking with regard to screenings. I'm talking about screenings of a different.
Well, blood pressure screening, I
Right.
think what Ed was saying before is really important, and that is prevention. We can do a lot of things in terms of prevention that we're not doing, like obesity, and being healthy, more exercise, checking blood pressure, that we're not doing. The Affordable Care Act, through developing accountable care organizations, the ACOs, which we have at Mount Sinai, is incentivizing us to do more primary care and more prevention than we've ever done before. That will be a very positive outcome, more screening.
There's a finite number of conditions where the screening actually is highly effective, and we have to be very sensitive to that. You know, you have entities that are advertising a whole body CT scan, and the notion, they'll give you an anecdotal example of someone who discovered a lung cancer or coronary artery calcification, but that's anecdotal. There are brutal statistical facts that you have to actually look at, and we can't ignore that one of the side products of screening in a non-thoughtful, rigorous way is a lot of anxiety and a lot of what we call incidentalomas that aren't actually.
There's this, what you're hearing is the average citizen can look at screening and apply a threefold test. Am I looking for something that is relatively common with a test that will find it where there is an intervention that will make a difference? It has to meet those three criteria. You're hearing examples where it does. Using expensive tests to look for very rare things where if you find them you can't make a difference isn't
I'm
screening.
basically talking about the basic. I'm not talking about the full body screening. I'm talking about a health specific condition, perhaps the PSA in certain case, perhaps an aortic.
Let's come back to
aneurysm,
Dennis's.
you
Let's
know,
come back to
for-
Dennis's point about genomics, though. This is where the genomic revolution, precision medicine, personalized medicine. There are a lot of jargon terms, but the reality is that by understanding more about genetic predisposition, prevention and tailored therapy becomes more possible. That's what we have to head for.
Are you training your students about that?
Absolutely.
That is my
Absolutely.
question.
Absolutely.
That is the point.
Absolutely.
Are you the difference? This wasn't. You weren't trained in this.
So we have all,
Didn't exist.
No,
Didn't
we
exist.
weren't.
yeah, we've all, I think, oriented our curriculum to make genomics be part literally of every year. And what many of us are also doing is trying to attract students from areas of science that traditionally have not gone to medical school, like expertise in physics and computational science and mathematics, because that is required for genomic research.
I mean, you know, besides genomics, I mean, 40 years ago, who did minimally invasive surgery? Okay, robots. Okay, I still wonder. You know, a physician is great, but a robot is taking care of your prostate, taking it out, or your gallbladder. It's a different condition.
We shouldn't get
I would view the robot as a physician extender.
Totally fascinated by technology. I mean, just because it's a robot doesn't necessarily make it we have to really look rigorously at outcomes. Do you want to touch on proton beam as an example?
Yeah.
Highly expensive example of here's a radiation oncologist. Tell us about proton beam. Is it justified?
For very specific diseases and typically rare diseases in children and certain brain tumors. The grand problem, proton beams are the black Death Star of medicine, a $500 million machine which is marketed to treat diseases which often don't need to be irradiated at all. So is it justified? For a child with a tumor of the base of skull, for a child with a cancer of the orbit, is it appropriate to treat a 71-year-old with a low PSA and a low-grade prostate cancer? Absolutely not. Is that what it's marketed for? Absolutely yes.
Hey, it's you know, let's remember, medicine is a business, as we were saying before, and it's not. The medical schools haven't done this, but the hospitals have. Every hospital and every hospital system advertises. And when I asked the question to your colleagues running the medical centers, they say, look, some of it we do just because we want to have community, and otherwise we do it because we want to publicize. We're in the competition. We're in the advertising business. To take the problem that we have with not enough healthcare allied professions, are we bringing more people from Europe? How are we going to absorb? How are we going to get enough people, as I said, not physicians, total allied health, to take care of our growing, aging population, the increase?
So I think we have to go back to comments that these two gentlemen made earlier, which is the business of medicine is driven by the way that things are paid for. And when we begin to pay medical entities to take on the complete responsibility for the health of a population, I'm not so sure we'll have such a shortage of all these caregivers. I think we'll completely reconceptualize our responsibilities professionally and how we go about delivering care, when that care is the responsibility lifelong of a group of patients, not the looking for the few procedures that happen to be well paid or even overpaid in a fee-for-service world.
I think a kind word has to be said. When you said every hospital system advertises, this would be a good time to say a kind word about the VA system in the United States. No, they don't advertise. They do spend a lot of time worrying about cost effectiveness. And in spite of people criticizing the VA, they do a very good job at cost-effective care of their patients with what's been proven to actually work.
It's absolutely true. The VA, I think when some of us trained, was actually the butt of some jokes, but they have advanced, they've embraced health IT, information technology, diabetes care. It's absolutely true. But I want to come back to the overriding point that Larry was just making. Look at our current system. It's incentivized to do kidney transplants and dialysis. That's business. That's high-end care. Those are failures of prevention. The major causes, uncontrolled blood pressure, diabetes. There are certain forms of end-stage kidney disease. If you have the genetic disease, polycystic kidney disease, we don't have a way of preventing that now. But the major forms of end-stage kidney disease, by the way, all reimbursed by Medicare. So those are failures of prevention. And as Larry said, if you have a completely different incentivized system, which is not fee-for-service, but instead emphasizes prevention on a lifelong basis, we can avoid those kinds of outcomes and save a lot of money, basically.
We talked last week, and perhaps at the beginning of this program, with regard to these advanced degrees and these advanced programs. Do you see more people going into advanced degrees and specialties over there?
We see more of our students wanting to get MPHs, Master of Public Health. When I stand in front of our first year classes and I ask how many of the students want to have an experience in global health, 80% of the students, raise their hand. And many of those students want to get masters in public health to learn more about how do you deliver public health, wellness programs, prevention programs to large populations. So that's become a much more popular advanced degree than 10 years ago.
My other question, which I brought up, the 7-year program, 3 years of medicine, or the shorter term program, where you could do the 3 years of undergraduate and then the 3 to 4 years. Do you see that more change?
We were all of a generation where several programs like the Boston University program and a couple of others where you can get into like a 6 or 7 year program right out of high school, that hasn't really grown.
The most recent studies on this have shown that most of the combined programs are back to 8 years. So it offers you ease of entree from undergraduate to medical school, but the 6 and 7 year programs have become quite the minority of these combined programs.
And what about what we said about what NYU is doing now on a 3-year program? Do you see any of your schools over the next couple of years going to a 3-year medical program?
We're going to pilot something similar to Texas Tech. Texas Tech, Mercer, and NYU have these, in which you combine the medical school experience with a family medicine residency, so that you do a 6-year program, 3 years of medical school, 3 years of family medicine, and come out with an MD in a family medicine specialty.
Yeah, like we were saying before, we've had the opposite experience. More of our students are spending an extra year for a research experience or
and that relates.
Global health
How many
experience.
of your students would you say are going to do research today? of your class? And
We have a very research-intensive school. We talked earlier about the MD PhD program. So 14 out of 183, by definition, are MD PhD and going into research. A significant number of the others do. It turns out there's something called the AAMC, Association of American Medical Colleges. They do a questionnaire of the students entering and then the graduation questionnaire. A huge number say they're going to go into research when they enter. The actual number later is smaller, but nonetheless, particularly in research-intensive schools, it's a significant number, and it ties in with one additional thing. It isn't just the MD PhD. It used to be clinical research, so-called. Research involving, one definition is where the doctor and the patient are in the same room and shaking hands with each other. Clinical research, clinical trials, very, very important if we're to advance. Used to be an MD was all you needed. Things have become much more complex, much more sophisticated. So you get a master's in science in clinical research, and we have students doing that.
But healthcare has changed. You know, many
Certainly.
years ago, you know, the average stay in a hospital was 10 days, 8 days. I mean, today, most procedures are done, day surgery. You know, this is what your institution is doing down in Manhattan over there on the former St. Vincent's, Montefiore's building up in the Bronx over there. You're doing it in many of your institutions. Okay, the ACOs have become a big item over there. And, you know, so the healthcare system has changed. Right. Where do you see, like with 30 seconds, where do you see where will the medical school training be? How different maybe in the next 10 years?
It would depend on the school. I think the research-intensive schools, those who have the most in NIH funding, will still be geared toward training the next generation of physician scientists. The tools will change. Genomics is going to be more dominant. The ability to do sophisticated imaging will be more prominent. So that will keep in the same direction as long as there's NIH funding. But more and more other schools will take on a different area of priority, like training more primary care doctors.
And you?
The challenge is that you always wanted the students to be where the patient is when the thinking about the patient and the decisions are happening. And that's going to force us to leave the hospital because that isn't necessarily where the thinking is occurring.
So I would like to say I'm very fortunate that I've had the four of you to provide me and my audience, and many people around the world will be able to watch this. And I'd like to thank Dr. Alan Spiegel, Dr. Dennis Charney, Dr. Edward Halperin, and Dr. Larry Smith, and I'll see you next week.